Welcome to your first obstetric skills drills. My name is Claire Bradley. I'm a midwifery clinical skills facilitator. I work as part of the midwifery education team who will facilitate your obstetric rotation here at University Hospital Sussex, both on the Brighton and Princess Royal sites. Firstly, I will discuss the pathophysiology of preeclampsia, how pregnant people present with this unique disease that is only found in pregnant humans. Finishing with an excellent film from the PROMPT course, which stands for the Practical Obstetric Multi-Professional Training Course. These courses have been found to be associated with improved clinical outcomes and reduced patient safety incidents. Let's begin with normal pregnancy to gain an understanding of the abnormal. Vasodilation is the primary change in circulation in pregnancy, with a 50% increase in plasma volume. Cardiac output has already increased by 20% at 8 weeks gestation, but the primary event is peripheral vasodilation. Blood pressure drops in the first and second trimesters, but increases again to non-pregnant status in the third trimester. Normotensive women can become transiently hypertensive following birth, peaking around day 3 to 6, due to the return to normal vascular tone and a period of vasomotor instability. For most women experiencing uncomplicated pregnancy, these changes resolve afterwards with minimal residual effect. Preeclampsia is a very serious disease related to high blood pressure. It can strike out of the blue with no apparent warning. The word eclampsia is Greek for lightning. It can strike any pregnant person, mostly in the second half of pregnancy and up to 6 weeks postpartum. It is a symptom of new onset hypertension and significant proteinuria after the 20th week of pregnancy. There is no cure. In the 1840s, doctors made an association of proteinuria and seizures, and in the 1870s, 25% of maternal deaths were due to eclampsia. Early in the 20th century, caesarean section was used to prevent maternal death. Here are some modern-day statistics. Hypertension complicates 10 to 15% of pregnancies. Mild preeclampsia affects 10% of women having their first baby, and severe preeclampsia only 1%. Eclampsia is rare, estimated at only 1 case for every 4,000 UK pregnancies. 63,000 maternal deaths annually are recorded worldwide. The death rate in developed countries is 0 to 1.8%, with black women reported to have a death rate 2 to 3 times higher than white women, due to socio-economic conditions, pre-existing medical conditions, and medical racism. Sadly, 1 in 6 women who have had preeclampsia will get it again. Although etiology is unknown, there is plenty of good evidence surrounding the pathophysiology of preeclampsia in relation to placental dysfunction. As well as genetic predisposition and the possibility of immunological and inflammatory responses in the mother, preeclampsia is a problem of placentation. This happens in the early stages, creating hypoperfusion of the placenta. During placentation, cytotrophoblast cells invade the uterine wall. These cells remodel the maternal vessels during early pregnancy, and the spiral arteries transform into large vessels of low resistance, allowing good blood flow between the uterus and placenta and ensuring a well-grown fetus. In preeclampsia, vasoconstriction occurs, leading to chronic ischemia of the placenta and its associated problems, such as intrauterine growth restriction. Due to the defective placentation under the influence of ischemia, endothelial damage will eventually occur. The disease process puts the pregnant person at risk of eclampsia, pulmonary edema, failure of the clotting system, HELLP syndrome, and renal failure. Here are some obstetric risk factors. Women older than 40 have double the risk of developing preeclampsia, even if it's their first baby or subsequent pregnancies. If their BMI is above 30, the risk is doubled. If their mother had it, they have a 20 to 25% of developing preeclampsia, but this jumps to 35 to 40% if their sister had it. You have a 2 to 3-fold risk if it's your first baby, a 7-fold risk if it's a multiple pregnancy, and if you haven't had a baby for 10 years or more, a 2 to 3-fold risk. A history of certain medical comorbidities, including chronic hypertension, diabetes, kidney disease, and a tendency to developing blood clots or lupus increases your risk of preeclampsia as well. During your clinical practice, you will meet pregnant people with a variety of clinical features affecting the renal, hepatic, cardiovascular, central nervous system, and coagulation systems. This will include raised blood pressure due to vasoconstriction, protein leakage in the urine. This is normally confined to the blood, but spilling over into urine due to a damaged filtration system, a redistribution of fluid causing widespread edema, usually pitting, pressure on the optic nerve from cerebral edema causing headaches, irritability, and focal disturbances, a swelling of the liver capsule causing nausea, vomiting, and pain, plus biochemical changes in liver function, potentially leading to HELLP syndrome, which is a severe form of preeclampsia affecting the liver and clotting systems. Subpregnant people will present asymptomatically of the disease process. Once a pregnant person is admitted to hospital and receiving treatment, it's possible for them to make a full recovery. However, estimated cases of 1 in 4,000 in the UK will experience an eclamptic convulsion or seizure. If cerebral blood flow is disturbed due to severe hypertension, then a pregnant person can suffer a stroke, suffering permanent damage and even death. Multi-organ failure may occur, pulmonary edema from a buildup of fluid preventing adequate oxygen absorption, kidney failure from the inability to filter waste products and toxins, and a disruption of liver function. HELLP syndrome is a rare liver and blood and clotting disorder. It stands for hemolysis, elevated liver enzymes, and low platelets. It's potentially as dangerous as eclampsia, and treatment is to deliver the baby as soon as possible. Clotting disorders include a breakdown of the clotting system and development of DIC, resulting in a lack of proteins to make the blood clot, and excessive bleeding or abnormal activity of these proteins, producing thrombosis and potential damage to the body's organs. Eclampsia is rare in the UK. During an eclamptic fit, there are jerky, involuntary twitches of limbs, loss of consciousness, and possible urinary incontinence lasting usually less than a minute. Most people will make a full recovery following eclampsia. However, there is a small risk of permanent disability, cerebral damage, or death of the mother or baby if the fit is severe. As you can see, they are most at risk in both the antepartum and postpartum periods. This slide shows the rates of preeclampsia and eclampsia per 100,000 maternities from the years 1985 through to modern day. And as you can see, the numbers significantly reduce. The Magpie trial in 1998 to 2001 was the reason for these drops in numbers. This was a multinational, multi-centre, randomised trial confirming claims that intravenous magnesium sulfate given before and during labour and for at least 24 hours following birth will reduce the risk of seizures in women with severe preeclampsia or imminent eclampsia, plus a 16% reduction in death or serious morbidity related to preeclampsia 2 to 3 years later. In 2016, Embrace, Mothers and Babies Reducing Risk Through Audit and Confidential Inquiries, highlighted that even though eclampsia has improved massively and only 1 in 1 million women currently die from eclampsia, the report highlighted that we still need to remain alert and vigilant to preeclampsia. You're now going to watch a small film from the Prompt team. This is of an antenatal woman experiencing an eclamptic fit and her subsequent treatment from the multidisciplinary team. You will get a chance to stop, pause, and discuss this with your facilitator within the room.